Next talk in our series of resident seminars. So thank you everyone for joining in. Tonight we're going to have a great talk from Dr. Christina Draganich. She's going to be talking about functional surgery of the upper extremity following tetraplegia. Just a little background about Dr. Draganich. She originally grew up in Chicago and then came out to Colorado and studied neuroscience at Colorado College down in Colorado Springs. She then worked both at Craig Hospital for 3 years and also did some time as a forensic biomechanics and analyst before she went to medical school at Rocky Vista University. And she is now a PGY2 here with us. So without further ado, take it away.
Thank you for that introduction, Vera. As Vera mentioned, before going to medical school, I spent 3 years working as a neurorehabilitation technician, or CNA, on the spinal cord injury unit at Craig Hospital. And during that time, I developed a passion for spinal cord injury medicine. And through that experience, and then also subsequent rotations in medical school and residency, I had the opportunity to see the positive impact of functional hand surgery in tetraplegia. So that's what I'll be discussing today. Our objectives for today's talk include being able to differentiate outcomes of tetraplegia by level of injury, identifying options for improving upper extremity function, implementing appropriate candidate selection for tendon transfers, nerve transfers, and neuroprostheses, utilizing the International Classification System for hand surgery and tetraplegia, and applying knowledge of upper extremity interventions to cases of individuals with tetraplegia. I would like to start by discussing a case of a patient that we had on the VA spinal cord injury unit. He was a 72-year-old gentleman with C2 AISC motor incomplete tetraplegia secondary to a fall in his yard. He reported that he was doing yard work with his grandson when he tripped and fell down 4 stairs, landing in cervical hyperextension with immediate onset of tetraplegia and no loss of consciousness. He ended up undergoing a C3 through C4 ACDF the day following his injury and initially required vasopressors for blood pressure support temporarily in the ICU, but had no further complications. His past medical history included hypertension and prostate cancer that had been complicated by a urethrorectal fistula, status post suprapubic tube and ileostomy tube placement. So he already had both of these prior to his surgery, and his past surgical history only included the ACDF. In terms of social history, he was a widower with 6 children, 17 grandchildren, and 7 great-grandchildren, and was actually caring for his daughter who was disabled at the time. He lived with 11 family members in a ranch-style house in the mountains, and previously had worked in construction and trucking, but was now retired and enjoyed yard work and fishing. Prior to his injury, he was independent with ADLs and mobility, but Mod-I for bowel and bladder. And on transfer to rehab, he was max assist for mobility, bowel, bladder, and ADLs. On presentation to acute rehabilitation approximately 1 month post-injury, his deficits included left greater than right upper extremity and lower extremity weakness, and his spinal cord injury-related complications included neurogenic bowel, for which he was on Senna and Miralax, neurogenic bladder, for which he was on trospium, neuropathic pain, for which he was being treated with gabapentin, and spasticity, for which he was on baclofen. He also had dysphagia and was on a moist mince diet. On exam, his ostomy was draining soft stool, his suprapubic tube was in place with some surrounding erythema due to a fungal infection, and his ACDF incision was well approximated. In terms of neurologic exam, he had a sensory and motor level of C2 on the right and C3 on the left, and as discussed on admission, he had the left greater than right upper and lower extremity weakness. He also had deep anal pressure and voluntary anal contraction on rectal exam with an ASIA exam that was consistent with C2 AISC incomplete tetraplegia. I've included his upper extremity motor scores that were obtained 3 weeks post-admission, and you can see here that he had some improvement in C5 and C8 motor scores bilaterally, and at this time his therapy goals were to operate his power wheelchair independently, assist with bed mobility, perform regular weight shifts, perform hand-to-mouth with his left upper extremity, direct his ADLs, perform slide board transfers with assistance, and assist with upper and lower body dressing. And many of these goals relied on improvement in his upper extremity functioning, which will be the focus of today's talk. So why is this important? There are approximately 12,000 new cases of spinal cord injury per year in the US, and 50% result in tetraplegia, with C5 being the most common injury level in all cases of spinal cord injury, and C4 and C6 being the next most common, meaning that the majority of these patients have the potential for significant decrease in upper extremity function. The literature supports a relationship between the level of injury and likely functional independence that a person with spinal cord injury can be expected to achieve. And although the establishment of expected functional outcome goals is beyond the scope of this talk, we will touch on it to form the foundation for discussing upper extremity function. This chart refers to individuals with motor complete tetraplegia. And as you can see, at levels C1 through C4, individuals are largely dependent for ADLs and transfers, but can be independent with power wheelchair propulsion, driving, and weight shifts. At the C5 level, with those muscles that are now innervated by C5 available, individuals gain some independence with feeding, grooming, upper extremity dressing, bathing, and bed mobility. At C6 level, individuals may be independent with feeding, grooming, and bathing, and at C7, they may be able to transfer themselves and propel a manual wheelchair. At C8 through T1, the individual is largely independent with ADLs and transfers. The literature has continually emphasized that increased arm and hand function is an important rehabilitation goal for most individuals with tetraplegia. In 1976, Hansen and Franklin showed that individuals preferred the restoration of hand function to the restoration of bowel, bladder, or sexual function. And in 2004, Snowick et al. Studied 565 individuals with tetraplegia and found that 77% had associated this improvement with quality in life with improved hand function as well. Here is a visual representation of desired functional recovery identified by individuals with spinal cord injury in Anderson et al. Study in 2004. This showed that the highest priority was arm and hand function, with just below 50% of 347 individuals indicating this as the most desired function over sexual function, bowel and bladder control, and even ambulation. There are several options for improving upper extremity function after tetraplegia, which include rehabilitation, which typically comprises conservative, compensatory, and adaptive techniques, non-invasive interventions such as splints, orthotics, and surface stimulation applications, and then finally invasive interventions such as tendon transfers, nerve transfers, and neuroprostheses. Here are some examples of non-invasive interventions. A tenodesis splint is an orthotic device that helps to guide grasp and release movement, and it relies on the tenodesis effect, in which the wrist extension will cause the fingers to flex, and then wrist flexion causes the fingers to extend. Thus, placing the wrist in extension causes a mechanical advantage, allowing for functional grasp. Both the wrist-driven flexor hinge splint and its powered version function based on the same principle. And the Bioness Surface FES uses surface electrical stimulation to activate muscles in addition to splinting, and can assist in both strengthening and also retraining upper extremity muscles. I've included a video here to show you an example of this tenodesis effect and what a type of tenodesis brace looks like. So as you can see here, as the wrist extends, the fingers flex, and as the wrist flexes, the fingers extend, and this causes or allows for functional grasp. And if we go a little bit later in the video, they actually show this being used functionally. So the individual is able to use this tenodesis effect to grasp a peg and then move it across the board and release it. The first of the more invasive interventions that we will discuss is tendon transfers, in which the functioning muscle and its tendon are detached from the muscle insertion and rerouted into a different muscle that assists to perform the function that requires restoration. The idea is that the donor muscle contracts and then powers a new motion. Ideal donor muscles are redundant so that there is no loss of function that the donor muscle initially provided. Many of the first tendon transfer procedures were devised to improve ambulation in polio patients, and then further advances were made in World War I and World War II. Before this time, mostly tendon transfers were for the lower extremity, but after this time, they started to be considered for the upper extremity. And then in the 1970s, Moberg took tendon transfer techniques for peripheral nerve injury and applied them to tetraplegia. Then, as we previously discussed, Hansen and Franklin in 1970s recognized that rehab should focus more on upper extremity function. And finally, in 1978, the international classification system that we'll discuss later was developed in Scotland. Appropriate candidate selection typically involves taking into account both behavioral and clinical factors. Typically, tendon transfers are performed in individuals with C5 through C8 motor levels and must be performed in individuals who are neurologically stable, have adequate range of motion, limited spasticity, and are at least 6 to 12 months out from injury with plateaued functional gains. It's also important to consider age and trunk stability. Typically, the surgical program is considered after the patient can sit, as the recumbent position causes the forearm to supinate, and especially this is the case if the individual has weak wrist extensors, so this makes postoperative re-education of the hand difficult. In terms of behavioral factors, history of compliance, motivation, expectations, and time from recovery are all important, given that depending on the procedure, postoperative recovery can be a lengthy process. Approximately 50 to 60% of individuals with tetraplegia end up being candidates. So, for example, our patient would not be an excellent candidate at this time given his age and his time since injury. However, his other clinical and behavioral factors would fit the profile for successful tendon transfer given his motivation, relative lack of spasticity, adequate range of motion, and also his extensive family support. Biomechanical considerations include the need for supple joints with adequate range of motion, as we discussed, soft tissue equilibrium with minimal scar tissue for adequate gliding, and the donor muscle also has to have adequate excursion and a straight line of pull to be positioned for maximal strength. Additionally, we typically only consider doing a single function gained per transfer so as to not have one donor muscle now causing multiple movements. Principles of reconstruction include building on the tenodesis effect, which we previously discussed, to allow for hand function to manipulate objects. It is important to note that palmar grasp is most commonly used for ADLs, and lateral pinch is actually used more often for ADLs than tip pinch, which forms the basis for the theory behind many tendon transfer techniques. Additionally, providing active elbow extension serves to expand the workspace to allow for an individual to effectively manipulate objects. Typically, elbow extension is restored first when performing tendon transfers to allow for adequate workspace, as we just discussed, and then wrist extension is restored second to aid with the tenodesis effect. And then finally, lateral pinch is restored for functional grasp. Appropriately selecting donor muscles for transfer is important to ensure adequate redundancy so that already preserved function is not lost. For example, the extensor carpi radialis longus, or ECRL, is typically transferred instead of the extensor carpi radialis brevis, or ECRB, because the ECRL has its insertion radial to the center of the wrist, which produces radial deviation with wrist extension, whereas the ECRB, with its central insertion on the base of the long finger metacarpal, produces wrist extension with minimal radial deviation, and thus is a more balanced and functional action to preserve. FCR is typically preserved as well, since voluntary wrist flexure action improves finger tenodesis extension and prevents wrist extension contractures. Biceps can typically be utilized as the brachialis is the primary elbow flexor. The individual may lose some flexion and supination strength, however, this may be desired in the setting of flexion spasticity or contraction. And brachioradialis is typically considered one of the most readily available and versatile muscles for transfer, as well as the deltoid and the pronator teres. The International Classification System for Surgery of the Hand in Tetraplegia was developed to identify candidates for upper extremity restoration, and it provides information regarding the number of voluntary muscles that are available for surgical transfer. Key muscle strength for potential donor muscles must be greater than or equal to 4. And Moberg developed additional sensory classifications, which include first the ocular group, in which only visual or ocular clues are available to help control the hand function. So the individual has poor sensation with over 10 millimeter 2-point discrimination in the pulp of the thumb. Whereas in the second group, the ocular cutaneous group, the individual has 2-point discrimination less than 10 millimeters, indicating poor sensation. And Moberg believed that this was an important consideration since there is a correlation between 2-point discrimination and accuracy of proprioception at the metacarpophalangeal and interphalangeal joints, which is required for adequate control of hand function without visual cues, and can provide additional information regarding the patient's appropriateness for tendon transfers. Here's an example of the international classification system taking into account the motor groups that are functioning, which are listed here as key muscle groups having a grade of 3 or above. And based on this, there's the creation of a classification motor group, which defines key muscles that are available for transfer. And again, remembering that these have to have a motor score of 4 or greater. More recently, it was modified to include the Asia system for classifying patients into different functional categories for hand reconstruction. We will first be discussing the C5 functional level, which includes international classification groups 0 and 1. This group has functional use of the deltoids, elbow flexors, brachioradialis, and possibly wrist or elbow extensors. And muscles available for transfer include the deltoid, biceps, and brachioradialis. Possible procedures in this group include the transfer of the brachioradialis to the ECRB to restore wrist extension, and transfer of the deltoid or biceps to the triceps to restore elbow extension. Goals here, as we just discussed, are restoring elbow and wrist extension, and then also potentially tenodesis-based lateral pinch. The first tendon transfer we'll discuss is the posterior deltoid to triceps transfer, in which the posterior deltoid is dissected away from the middle deltoid, and then the distal deltoid is attached to a free tendon graft from the leg, which can either be the anterior tibialis or the flexor hallucis longus. This is then attached to the tricep tendon, which allows for active elbow extension and enables the patient to stabilize themselves for sitting or transferring. It is important to note that the small size of the deltoid leads to the need for the bridging tissue graft, and because of this, post-surgical rehab becomes longer and more demanding to avoid stretching or weakening of the graft. Several studies have looked at this procedure. Roxa et al. In 1984 looked at 22 patients who had undergone this procedure and found that 14 of them reported functional improvement, with 13 specifically reporting that they had increased independence. They reported the ability to stabilize their arm and reach overhead, improvement in grooming, personal hygiene, pressure relief, writing speed and clarity, and also feeding. And in 2012, Wangdell et al. Found that individuals who underwent this procedure had improved ability to reach objects easily, drive a wheelchair, self-transfer, write, and stretch their arm when they were laying down. Another potential tendon transfer in this classification group is the biceps to triceps transfer. Benefits include that the biceps may provide more strength than the deltoid, and additionally, the biceps tendon can be inserted directly into the triceps, given the longer length of the muscle, and thus less time is needed for postoperative rehab. So many surgeons prefer this technique. Kozin et al. In 2010 studied a total of 75 arms in 45 patients that had undergone a biceps to triceps transfer, and found that after the procedure, 75% were able to function overhead, whereas they could not before. And there was also an improvement in dressing, grooming, wheelchair propulsion, and recreational activities. The last potential tendon transfer in this classification group is the brachioradialis to ECRB transfer, which includes detaching the tendinous insertion of the brachioradialis and connecting it to a tensiometer to measure the strength of the brachioradialis in order to determine its suitability. This is because it is difficult often to determine the strength of the brachioradialis by manual muscle testing, because you often can't isolate its contribution to elbow flexion from the biceps and the brachialis. Interestingly, patients with 1 out of 5 or 2 out of 5 wrist strength preoperatively have often had adequate strength for a brachioradialis to ECRB transfer that was successful in the literature. It's important to note that this procedure typically provides between 3 and 5 out of 5 strength, and 4 out of 5 strength is required for lateral pinch if you follow this procedure with a surgical tenodesis of the FPL, if the plan is to proceed with that procedure afterwards. Next, we'll discuss the C6 functional level, which is primarily international classifications 2, 3, and 4. This group has functional use of the biceps, brachioradialis, ECRL, ECRB, FCR, and pronator teres, and muscles available for transfer include the brachioradialis, ECRL, and pronator teres. Goals of these procedures are to restore elbow extension, lateral pinch, and palmar grasp. The restoration of lateral pinch can allow for self-catheterization, writing, and feeding, among many other ADLs. And at this classification, there is often consideration of performing single versus 2-stage procedures. The first procedure we'll discuss is the Moberg key grip procedure, or passive FPL tenodesis procedure, which is actually not used as often anymore because newer procedures that we will discuss have become more common. However, patients who had tendon transfers done in prior decades may still have received this procedure, so it's important to know about. This procedure is whereby there is a surgical creation of FPL tenodesis by securing the proximal end of the FPL to the distal radius, and then an intermedullary screw is inserted via the distal tip of the thumb across the IP joint to allow thumb IP joint extension. Extensor pollicis longus and brevis tendons are then secured proximal to the MCP joint to prevent excess flexion. This does require wrist extension to already be present for the patient. Several studies have examined the efficacy of this procedure. In 1981, Coyer and Kappelman looked at 8 patients who had this procedure done and found that 6 were happy with the results, and 3 specifically said that they could perform self-catheterization, and 1 was able to handle papers. In 1986, Reiser and Waters looked at 9 patients who had had this procedure an average of 7.4 years prior and found that 7 of the 9 reported improved function. Specifically, they talked about improvement in grooming, eating, writing, and desktop skills. Most surgeons agree that when possible, transfer of active motor to the FPL to provide lateral pinch is preferable to the FPL tenodesis procedure that we previously discussed. This is because passive tenodesis control of distal function by proximal joint movement eliminates a degree of freedom of the hand and precise movement because wrist motion must accompany pinch. Active procedures are also better able to stretch, so hands can be used then for weight bearing, transfers, and wheelchair propulsion. In order to restore lateral pinch, several procedures can be done, including the brachioradialis pronator teres or ECRL transfer to the FPL. And in order to restore finger flexion, several procedures can be done, including brachioradialis pronator teres or ECL transfer to the FDP. Some feel that the pronator teres is the most expendable muscle and easiest to transfer, but this is mostly surgeon dependent. Several studies have examined the efficacy of these procedures. Lam and Chan et al. In 1983 looked at brachioradialis to FPL transfers and ECRL to FDP transfers, and they found that 83% of patients who had these procedures done reported excellent results with improvement in function, and no patients experienced impairment from the surgeries. Waters et al. In 1993 looked specifically at the brachioradialis to FPL transfer and found that 15 out of 17 patients who underwent this procedure had functional improvement, with 12 specifically reporting improved grooming and mobility, and 9 able to write after the procedure. And then in 2010, Guinée et al. Also studied a handful of these procedures and found that 75% of individuals who underwent lateral pinch reconstruction were able to self-catheterize and also reported resultant functional improvement after the surgery. The C6 functional group may also lack triceps function depending on the individual. So in this case, posterior deltoid to triceps transfer should be performed beforehand reconstruction to allow for optimal function of the brachioradialis when it's transferred. Brez and Waters et al. In 1987 found that pinch strength increased 150% when elbow was stabilized in orthosis compared to when the elbow was unrestricted, and that was the basis for this recommendation. I did also want to mention paralytic supination deformity, which may be present in patients with active elbow flexion and wrist extension, specifically in injuries caudal to C5. This is based on the principle that when the forearm is supinated, unopposed gravity maintains the wrist in dorsiflexion, and then active wrist dorsiflexion is unavailable. Many ADLs require pronation, such as grooming, feeding, writing, and wheelchair propulsion, so functional use of the extremity is then limited if there is a supination deformity. There is a procedure, however, available to address this issue, which involves rerouting the biceps brachii dorsally and laterally around the radial neck, as I've pictured here. In 1994, Gelman et al. Studied this procedure in 6 patients with traumatic tetraplegia who had undergone the lengthening and rerouting of the biceps. 8 arms total were surgically treated, and if the dominant hand was treated, patients reported improvement in self-feeding, personal hygiene, writing, and typing, and there was no decrease in elbow flexion strength postoperatively. Maximal gains in range of motion were noted around 3 months, while maximal functional gains occurred 6 months postoperatively. And postoperatively, passive pronation of 90 degrees was obtained in 7 out of 8 arms. And at 27-month follow-up, all patients had retained at least 80 degrees of pronation. Next, we'll discuss the C7 functional level, which includes international classification groups 5, 6, and 7. These individuals have functional use of the wrist extensors, pronator teres, fingers extensors, and triceps, and muscles available for transfer include the ECRL, FCU, pronator teres, and brachioradialis. At this level, individuals may not require an elbow extension transfer, so goals may focus more on restoring lateral pinch and palmar grasp. Single versus two-stage procedures are considered even more often at this level, and these individuals lack finger and thumb flexion and intrinsic musculature of the hand. However, they may have active finger and thumb extensions, so they do not develop the natural tenodesis of finger flexor tendons, which means that sometimes they may actually be less functional preoperatively than C6 individuals who lack active finger extension. Tendon transfer procedures for C7 level include procedures to restore finger flexion and thumb flexion. Procedures aim to improve finger flexion uses either the ECRL, FCU, or pronator teres in a transfer to the FDP, and then procedures aim to improve thumb flexion include brachioradialis to FPL transfers. In 1985, Ainsley et al. Looked at 23 patients who had one of these procedures done and found that 21 of them were glad they underwent a procedure. They reported gains in self-care activities and decreased needs for attendance. They also reported that the average grasp strength 1 year post-injury was 13 pounds, and average lateral pinch strength 1 year post-surgery was 5 pounds. We should note that hand grip strength for an individual without tetraplegia is on average between 105 and 113 pounds, and palmar pinch or 3-point pinch on average is approximately 26 pounds. So there's still quite a difference from individuals without tetraplegia. Finally, we'll discuss the C8 functional level, which includes international classifications 8 and 9. These individuals have use of extrinsic muscle function, however, they lack intrinsic hand musculature. Thus, unopposed extrinsic function may result in a claw hand posture. Studies have shown inconsistent results from tendon transfers to restore intrinsic function, although individuals may benefit from restoration of intrinsic thumb musculature. Typically, FDS and FDP are the muscles that are available for transfer in this group. Freehafer et al. In 1997 developed one such procedure whereby the tendon of FDS is detached proximally and anastomosed to the distal end of the pronator teres, which is then detached from the radius. The FDS tendon is cut distally at the level of the MCP joint of the ring finger and retrieved in the palm of the distal transverse carpal ligament. It's then rerouted and inserted into the tendon of the adductor pollicis brevis. This substitutes for paralysis of the adductor pollicis and improves pinch strength against the side of the index finger. I was not able to find any studies looking at the efficacy of this procedure, unfortunately. EMG studies have showed that complete re-education of the muscles of transferred tendons occurs following training. In 1990, Waters et al. Looked at EMGs in patients after brachioradialis to FPL transfer to restore lateral pinch. And as you can see here, after the brachioradialis was transferred to the FPL showed a similar integrated EMG force curve following transfer of the brachioradialis as the brachioradialis had prior to transfer. So the FPL developed the same recruitment pattern of primary motor. Limitations in measuring outcomes after tendon transfer include that standard measures are not consistently used, and measures that are used are not always available and easily used in clinical settings. Additionally, many outcomes, as you've seen, are based on subjective reports of satisfaction, and most of the studies we've discussed have had very small sample sizes. Some barriers to patients receiving tendon transfers include lack of interdisciplinary association between surgeons and physiatrists, and the belief that third-party payers do not reimburse for treatment of upper extremity and spinal cord injury, which from my discussions with attendings does seem to be the case some of the time, but not necessarily all of the time. Rehospitalization rates for other complications that may prevent these individuals from getting procedures is also another consideration. If they're hospitalized for other complications of spinal cord injury, they may not even be able to consider undergoing one of these procedures. As I mentioned previously, tendon transfer success is dependent on effective postoperative rehabilitation, which consists first of an early postoperative care phase. And that includes immobilization, which previously was up to 4 weeks, but now can be between 1 and 4 weeks and more often involves early mobilization, dependent on the opinion of the surgeon. It often involves casting and removable splints, and it's very important during this phase to maintain range of motion of the surrounding joints to prevent contractures. Traditional therapy includes protective splinting, scar mobilization, retrograde massage, tendon transfer gliding, active range of motion, and re-education. And ultimately, these individuals must learn how to initiate new motions. Sometimes FES and biofeedback is also used in retraining. We've discussed a lot of technical details of tendon transfers, including the fact that the available studies are limited and outcomes can be based on subjective reports a lot of the time. So I wanted to show this video of the results of a tendon transfer in the patient's own words so that you could hear his experience.
September 22nd, 2015, I had a bad fall at work and had a spinal cord injury to my C5 and C6 vertebra.
Currently, there are about 300,000 people in the United States who are living with spinal cord injuries, about 18,000 new injuries a year. The higher up, the closer to the brain, the less function people have in the arms. As the injury occurs lower, there's more function.
The chair is able to give me a lot of mobility. It's not the same as walking, but I'm able to get around without really much restriction or fatigue. However, when it comes to picking up small things, taking a drink, reaching for something in a cupboard, it's really difficult being able to do those things.
For many individuals, there are duplicate muscles, meaning there are two different muscles that do the same job. We only need one of those two muscles to be functioning. Therefore, there is one which is a donor muscle. We can cut the tendon of that donor functioning muscle and move it to the tendon of a muscle which is no longer functioning, and thereby restore the activity of the lost function.
This hand, I wasn't able to open or close at all. It was just completely passive. I wasn't able to pinch with either one of my thumbs, and I got a lot of pain in both my thumbs from trying to use them. So being able to actively grasp something or pinch something was not possible for me. And then I also had no tricep function either.
His expectations met what we can surgically provide, and as such, he was really motivated to try to use these surgeries. Treating patients with cervical spinal cord injury for tendon transfers requires a team approach. Our team works together to identify patients who are ideal candidates for these procedures. After surgery, we coordinate the postoperative therapy, which is as important as the surgery itself.
So now with this hand, I'm able to open the fingers up much farther than I was able to before, and I'm able to close them. And when I close them, I have a tight grip. And then my thumb also comes down and pinches and gives me a good amount of pinch as well. Because my thumb is fused, I don't have that pain in my joints from that thumb being stretched all over. Also in my tricep, I'm able to extend my arm out at zero gravity and even against gravity. Before, this hand was restricted to almost just being able to push things with it, to where now I can hold things. I'm able to control them a lot better. I'm able to maintain a grasp for things from picking up cups to brushing my teeth to using my phone. So I have a lot more ability with both hands and in both arms too.
These are the most satisfying patients with whom I get to work. To see someone who has difficulty with everyday activities, holding onto a knife or fork, not being able to hold onto a pen without weaving it through their fingers, a teenage boy who has to have mom place a urinary catheter instead of being able to do it for himself, and then to do the operations and have him activate that muscle, and for the first time he can pinch when he hasn't been able to do that since the time of his injury. See that look in their eye, their face light up, that function is back, is really one of the most rewarding things I get to do.
During my time at Craig, I was able to work with several patients who had similar experiences where their quality of life and functional independence were greatly improved after tendon transfer surgery. This patient also brings up an important point that successful surgeries can also serve to decrease pain as well as increase function. I would like to transition to talking about nerve transfers. The principle of nerve transfers are similar to tendon transfers, whereby the expendable donor nerve branch within a nerve trunk is used to re-innervate a paralyzed muscle. Compared to tendon transfers, there are more variable results for return of meaningful function and less immobilization, but longer time frame to regain function. Additionally, procedures need to be performed by 12 to 18 months to prevent degeneration of target muscles, and within 9 to 12 months if there is a lower motor neuron injury. Spasticity is not a contraindication, as it in fact suggests preservation of the motor neuron and lack of atrophy. Two of the main goals of nerve transfers are to improve elbow extension and wrist extension, similar to tendon transfers. For elbow extension, there are a couple of possible procedures. In the first, the motor branch to posterior deltoid is used to innervate the triceps. However, this eliminates the possibility of use of the posterior deltoid for salvage tendon transfer later. The second is the motor branch to teres minor transfer to the triceps. This is often preferred because if the procedure fails, then it still allows for the deltoid to be used for salvage tendon transfer. For wrist extension, often the motor branch to brachialis is used to innervate the ECRL. However, this rarely creates enough power for effective tenodesis, pinch, and grasp, although it typically does eliminate some of the need for a universal cuff, so it does have some potential efficacy. Restoration of lateral pinch is another goal of nerve transfers and involves the restoration of AIN via motor branches to brachialis, supinator, ECRB, or ECRL to allow for palmar grasp. In 2014, Van Zyl et al. Published a case report where they studied the brachialis nerve to AIN procedure to restore FDS and FPL function. And they found that this restored pinch and grasp strength up to 0.9 kilograms and 7 kilograms 17 months post-surgery. Theoretically, lateral pinch also requires small finger flexion, and I found one study that looked at this. In 2015, Fox et al. Found that the brachialis nerve to AIN and FDS nerve transfer resulted in lower grasp strength than brachialis nerve to AIN transfer alone, likely because brachialis has insufficient caliber to reinnervate both muscles. However, further research is needed to parse this out. Nerve transfers in tetraplegia are much newer than tendon transfers, and as a result have much less research available for review. Also, as we have discussed, it takes much longer to know if the surgery has been successful. I couldn't find a video showing a patient who had gone through the healing and retraining process, but did want to show this short video where a patient and his surgeons talk about the pre-surgical and surgical process.
We will just trim these stitches today so that they're not so irritating.
Timothy Ragland may soon be able to move his fingers for the first time in 7 years after a team of surgeons at the Ottawa Hospital performed Canada's first ever nerve transfer surgery on a quadriplegic patient.
So it was that summer afternoon about 7 years or so ago, and I was working at the cottage doing some work in the boathouse, and I decided to go for a swim before supper time. The year that I dove in was little, the water was shallow, and I hit the bottom and realized right away what happened, and had to try and hold my breath as long as I can. Luckily, there was friends and family around that were able to help me get out of the water and to a helicopter very quickly. Took care of me pretty fast.
The nerve that lets Ragland pinch his right thumb and forefinger has been disconnected from his brain since the accident.
That's nice. That's what we're going to do.
Yeah,
that's good.
And during surgery, the team connected it to a donor nerve from a muscle that bends the elbow.
So for Mr. Ragland, the two things that we really wanted to try and achieve for him were some degree of pinch and finger flexion and some degree of finger and thumb extension to open his hand. So the idea would be that he could grasp and release eventually.
Nerve transfer surgery has only been performed on patients with spinal cord injuries a handful of times at one American hospital.
I think it's amazing when I heard that the doctors were coming out from the States and what the team they assembled for this surgery. I'm not used to that type of attention or special treatment. So, yeah, I was quite honored, thrilled that I was able to do it. I was eligible. So, I'm very thankful to all of you for that help.
The nerves will die beyond where they were cut and sewn together, but the tubes that contain them will remain. The nerve should regrow down this pathway and branch out into the muscles at about 1 inch per month. It could take a year to see results.
And it'll just be the same life as he's known it. It's not going to be any different. He's not going to notice any change, hopefully for better or worse in his function. And then we have to wait. So that's going to be the hard part, because these transfers probably we won't know for at least like 6 to 9 months at the earliest we might start to see something, and realistically, Dr. McKinnon tells them about a year.
If it's just a simple pinch to pick up grapes, to feed myself grapes or chips or whatever, I'm happy. At least I got something, I can pick up a toothbrush, I can pick up a Phoenix and blow my nose, or I can at least do stuff like that I can't do now,
Finally, I wanted to touch on implantable neuroprostheses, which are devices that use electrodes to interface with the nervous system and aim to restore upper extremity function. Candidates for this include individuals with level of injury between C4 and C7, individuals who are free of contractures, and those who have good compliance. So similar to candidates for nerve transfers and tendon transfers. Limitations include cost, surgical risks, and training. One example of an implantable neuroprosthesis is the freehand system, which was the only commercially implantable FDS system available to improve grasp and was capable of both palmar and lateral grasp, although it is unfortunately no longer on the market. It is an 8-channel implantable stimulator that allows active opening and closing of the hand, and an external controller on the contralateral side is used to control a degree of hand opening. Contraction occurs by voluntary motion of the contralateral shoulder or ipsilateral wrist, and from what I could find, the company stated that the system provided improved ADL independence to nearly all of the 250 individuals who had this implanted. However, I could only find case studies and case reports in the literature to support this. All right, so finally, I wanted to bring this back to our patient, KG, and discuss what kind of intervention might work best for him. Our therapists were already working with him on rehabilitation techniques to improve upper extremity function, and also using non-invasive interventions such as splints and orthotics. In terms of non-invasive procedures, he would likely be best suited to a tendon transfer, with the 2 caveats being his age and then also his time post-injury, as we previously discussed, as he has not yet gotten to 6 to 12 months out from his injury with plateaued neurologic function. However, I have still listed both his most recent upper extremity Asia motor scores and manual testing of possible muscles available for transfer. As we previously discussed, the first action we focus on restoring is elbow extension to expand the workspace. And he has enough strength on the right to be able to perform elbow extension, but not on the left. As you can see here, his bilateral deltoids are the only muscles that are above 4 for motor scores and thus good options for transfer. So the best intervention for him would be to perform a left-sided deltoid to triceps transfer. In summary, increased upper extremity function is an important goal for individuals with tetraplegia, and there are multiple options available for improved upper extremity function, including therapy, splinting and bracing, tendon transfers, and nerve transfers. Compared to tendon transfers, nerve transfers have shown more variable results, require less immobilization, but ultimately longer time frame to regain function, and must be performed by 18 months post-injury. And ultimately, more research is needed with standardized measures to assess outcomes from functional upper extremity surgery. I've included my references here. Feel free to reach out if you would like copies of any of them. And at this point, I'll open it up for questions.
Thank you so much, Christina. I'll read you, there was a question that came in through the chat. So could you talk a little bit more about the recovery process? Is therapy mostly done in the outpatient setting?
Yes, great question. So from what I read, it's mostly done in the outpatient setting. Sometimes individuals will end up staying overnight for surgery, but it typically isn't a very long hospitalization. And oftentimes for these individuals, as we mentioned, these surgeries are happening 6 to 12 months out from injury, so they're usually no longer in their acute rehabilitation stay. In terms of what therapies include, a lot of the thought process most recently, as I mentioned, is more going towards early mobilization, which I thought was interesting. So they recently used to do serial casting, which would occur for up to 4 weeks and only range of motion in the surrounding joints. But now the most recent literature I saw is saying that early mobilization is better. And so they'll actually start range of motion of that joint specifically in that early phase. I don't know if that answered the question.
I think that was great. I had a quick question. We talked a little bit about both the tendon transfers and the nerve transfers. Did you read much about those being used in conjunction or one after the other? I know it seems like nerve transfers are a little earlier, so.
Yes, so I did actually read an interesting paper on that. In 2018, a group of authors came up with a classification system that included both nerve and tendon transfers. So it was similar to the tendon transfer classification we talked about, but the idea was to use selected donor nerve transfers, which avoided sacrificing useful muscles in order to allow for two-stage procedures. So for example, in one classification group, they recommended a teres minor nerve to triceps tendon transfer to restore elbow extension. And then if that was unsuccessful, the next stage was to pursue a tendon transfer, which is an example of kind of having a contingency plan in the event of unsuccessful first surgery. While another example in their classification system was to start with a nerve to teres minor to triceps nerve transfer, and then if this was successful, then do a specific tendon transfer after that to build on that effect. And so that was kind of how they combined both ideas. And I did find one study that looked at 10 patients who had nerve transfers and tendon transfers that were performed in the same limb, who subjectively found that these combined procedures were helpful and they actually did better on functional tasks.
That's great. I'm going to keep reading some of these questions that are coming in the chat, but people can also feel free to ask as well. I also stopped sharing your screen just so we could try to have a little more conversation. So, but if you need to throw your slides back up, you definitely can. Let's see. And then Andrew Park said, awesome job, Christina. You mentioned optimal time for tendon transfers. Is there similar optimal timing for nerve transfers?
Yes, it is similar in that I was reading typically they won't do them until 6 months out from injury with neurologic stability. However, the one difference is that they try to do the nerve transfers a little bit sooner than the tendon transfers. Sometimes individuals will get tendon transfers up to a couple of years out. And that's because typically the process of neuromuscular degeneration is slow. However, with the nerve transfers, you have to do it typically within an 18-month period.
Hi, Christina. It's Dr. Ladley. Question about freehand, and I apologize. I was having some volume issues when you were talking about that system. When I was a fellow, it was a new technique, and I had a couple patients who went through it successfully. But I understood it wasn't available for a period of time, like the company went out of business. What's, the status of its availability?
Yeah. So unfortunately, it's actually no longer available from my reading, which is too bad because it looked like there was quite a bit of success with it. And it looks like they're working now to see if they can get it back on the market. And there are a couple other companies working on other systems, but nothing that's currently widely available outside of research studies.
Yeah, I think we had spoken to a senior hand therapist from New York who came to interview at Denver Health, and he was talking about having that be a goal, like a career goal. So we'll see, I guess.
Yeah, that would be great. And did you, Dr. Ladley, did you get to work with any patients who had the system implanted?
Yeah, just a couple. I want to say that I met some people who were, kind of halfway through the outpatient process, and it was going very well. I remember one gentleman in particular was coming from Alaska. So it was quite a complicated thing. He would come in for updates and kind of work with the therapist and go home and do more on his own. But it was going very well, I would say. Yeah.
That's great to hear. Thank you for sharing that.
You bet.
All right. And then Mark asked, or he said, great talk, Christina. How many providers are doing this in Denver?
That is a great question. I only know of a couple surgeons through Craig who were performing these procedures, but I'm not sure if there are other providers that are doing this throughout Denver or Colorado in general. I'm not sure if any of the spinal cord attendings can speak to that.
Certainly not at Denver Health.
This is Andrew, and great job again, Christina. We just actually have a brand new plastic surgeon, Dr. Endres, who trained at Stanford on nerve transfer techniques. is very interested in working with us. I have a patient with, it's a little different because it's peripheral nerve injury, but who has a C5, C6 nerve root avulsion, and are looking into doing an inpatient neurotransfer for that. But that's relatively brand new. Before that, my understanding is that we were just mostly doing tendon transfers.
I believe there's at least one orthopedic hand surgeon at Children's that's doing nerve transfers. Dr. Sarah Sibyl, I've seen her do them for patients with brachial plexus injuries and then acute flaccid myelitis. And there might be more. She's just the one I've seen her name on charts most often.
And then at university, we have the whole peripheral nerve clinic, which isn't dedicated just to spinal cord injury, but has Ben Marshall working with a couple different neurosurgeons on how to optimize things for these similar but different types of patients.
But peripheral nerve clinic and nerve surgeries, they are much more common. And so I will amend my previous answer to say, yeah, we're doing nerve grafting and that type of thing at Denver Health. But I'm not clear that anyone outside of the Craig consultants is doing anything for spinal cord patients. Correct me if I'm wrong.
All right, there are a few more chats coming in, but there was one question from Allison about if these procedures are done by hand, plastics, and I think we've heard plastics, and then also neurosurgery and some ortho hand as well.
Yeah, and that was consistent with what I read, and it sounds like with everybody's experiences.
And then Dr. Ryder also mentioned Mickey Gordon at the VA does tendon transfers as well. I was curious, did you see anything about longevity for the tendon transfers? So it seemed like there was one study that mentioned like 7 years out, patients were still pretty satisfied. Any data or even just anecdotal, anything longer than 7 years that you've heard about?
So from all of the studies that I read, the longest that they had studied it was 10 years out in one of the samples that we discussed. I didn't see anything after that point or any discussions on longevity, but that was a question of mine as well, Vera. I did know one patient who was a chronic patient at Craig who had had a tendon transfer, I think it was 15 years prior, and said that it was still functioning just as well as it had initially. And my guess would be, that given that you get a similar EMG force curve as the initial muscle, if you're still using it and you're not getting a lot of atrophy, probably it would hold up pretty well. But I don't know in terms of the technique with, how they surgically incise the different muscles. I don't know if anybody else has, any of the faculty has more insight on that.
Completely on my just clinical experience, they last. It goes well.
Awesome. Thanks, Dr. Ladley.
Well, I think that was a really great talk, Christina. It was so great to get to hear from that. We know SCI is a really big area of passion for you, so fun to get to hear you talk about that. And I think you did a really good job kind of covering all of those two areas and kind of explaining how patients could really benefit from this. So if anyone has any other questions, they can reach out to Christina by email, but otherwise, hopefully we'll get to celebrate all of the resident seminars sometime soon in person. But until then, thanks for another great seminar.
Well, thank you all so much for listening, and thank you for the great discussion afterwards.
Christina, can you stay on for just a second and share your title screen again for us?
Definitely.
Grab a pic of you.
Yes. That now.
Tradition when we're in person, so we'll try to keep it going.
Awesome. Thanks for doing that, Malia.
Yeah. I hope it comes out.
Slow to share. Give me 1 second.
Yeah, take a second because I need to pull up and see if it'll.
And then don't forget to look at the chat because you're getting a lot of great jobs and whatnot. So make sure you get your kudos.
And thanks.
You did an awesome job, Christina.
Thank you. Can you see the PowerPoint, Malia?
Yes, just maybe one I'm trying to pull up. I'm gonna like print screen and then see if the picture comes out clear when yeah, great. Okay, so I got one that wasn't so flattering when you were talking, so I figured you'd appreciate a better picture to be.
I do appreciate it.
All right, I'm gonna make your picture bigger. Cool. I'll tell you when I'm ready so your cheeks don't get sore.
Okay, sounds good. You're thinking about all the things.
I'm trying to get your whole title slide and your picture and make your face bigger. All right, almost done. Great, okay. Tell me when you're ready.
Crushed it.
Thanks.
Oh, well, now you're in our picture.
Nice.
What's coming well in the picture?
All right, smile big. All right, let me get a couple. Oh, wait, I can't. Yeah, the time. All right, let me see if that one came out. I'm like putting it.
Just let me know when.
Will's ready.
This is very, I'm sure someone is more tech savvy than me that would have found out a better way to do this, but I am.
I promise you're more tech savvy than I am.
Malia, stop talking, and then Christina talks so that her picture shows up, and I'll take a picture.
Oh no, she was showing up on mine, so my bad.
I'm gonna start